Welcome to the American Society of Echo E3 lecture series. My name is Lucy Safi and I am Director of Interventional Echocardiography at Hackensack Medical Center and Chair of the ASE Emerging Echo Enthusiasts, also known as E3 Special Interest Group. This special interest group provides an opportunity for early career physicians, sonographers, and trainees who are interested in echocardiography to present, interact, and discuss echocardiographic topics. Each lecture is formatted as a 30-minute didactic lecture followed by a panel discussion. On the panel will be 2 moderators and an expert in the field. During the discussion section, the panelists will also answer audience questions, so please enter your questions in the question and answer box below. This virtual lecture series will be recorded and later available online at the ASE E3 website. To join E3, log on to your ASE account and click Update My Profile under Special Interest Group, select Emerging Echo Enthusiasts. Today's topic will be assessment of aortic stenosis. It is my pleasure to introduce you to my co-moderator and co-chair of the ASE E3 Special Interest Group, Dr. Serge Harb. Dr. Harb is a cardiologist who received his medical degree from St. Joseph's University, then completed his internal medicine, cardiology, and advanced cardiac imaging training at Cleveland Clinic main campus. He then remained on staff as a cardiologist at the Cleveland Clinic with a special interest in valvular heart disease. Welcome, Dr. Harb. Thank you for joining us today. Our expert today is Dr. Alfonso Waller. Dr. Waller is an associate professor of medicine and radiology and is the director of cardiac imaging at Rutgers, New Jersey Medical School and medical director of the Echo Lab. Dr. Waller completed his internal medicine residency and cardiovascular disease fellowship at New Jersey Medical School. He subsequently completed an advanced cardiovascular imaging fellowship and served as chief fellow at the Advanced Cardiovascular Imaging Program at Brigham and Women's Hospital, Harvard Medical School. Dr. Waller has extensive clinical expertise in multimodality cardiovascular imaging and has published peer-reviewed manuscripts in the fields of cardiac MRI, cardiac CT, nuclear cardiology, and advanced echocardiography. His clinical and research interests include optimal selection between imaging tests and comparative effectiveness of cardiovascular imaging. It is a privilege to have you with us here today, Dr. Waller. Our speaker today is Dr. Aishwarya Bhardwaj. Dr. Bhardwaj is originally from Ontario, Canada. She received her Bachelor of Science from McMaster University in Hamilton, Ontario. She earned her medical degree from St. George's University in Grenada and completed internal medicine residency at the State University of New York, SUNY Buffalo. She is currently completing her 3rd year cardiology fellow and chief fellow at Rutgers, New Jersey Medical School. Welcome, Dr. Bhardwaj. The stage is yours.
Thank you, Dr. Safi, for that wonderful introduction. Hello, everyone. My name is Aishwarya, like Dr. Safi said, and I am very lucky for this opportunity to be able to give this talk today. I have no disclosures. So on today's agenda, we will be discussing the etiology of aortic stenosis, grading AS severity, going over some pertinent echo parameters, staging of aortic stenosis, and we'll finally talk about what makes for a comprehensive echo report in an AS study. So as we can see, this is a normal aortic valve seen in the parasternal short axis view with 3 cusps, namely the non-coronating, the left cusp, as well as the right cusp, with normal leaflet excursion and opening as seen during systole. So aortic stenosis can be valvular, subvalvular, or supravalvular. However, for the purpose of today's discussion, we will be focusing on valvular aortic stenosis. There are various etiologies of aortic stenosis, with the most common one being congenital valvular abnormalities, as well as age-related or degenerative AS. There's also rheumatic AS, radiation-induced aortic stenosis, as well as some other rare causes. When considering congenital malformations, we can see here, we can have a unicuspid aortic valve. This is extremely rare. These patients tend to present in early childhood with signs and symptoms of heart failure, as well as aortic stenosis. So we can see a single cusp right here. In the middle here, we see bicuspid aortic valve. This is by far the most common congenital malformation seen in clinical practice, and it's associated with aortic dilation, as well as coarctation of aorta. Therefore, in patients with bicuspid aortic valves, assessment as well as reporting of aorta is crucial. These also tend to run in families, so screening of first-degree relatives with echocardiogram is also advised. And up top here, we see a quadricuspid aortic valve. These are also associated with aortic stenosis, but tend to have more aortic insufficiency. So when to suspect bicuspid aortic valve? Well, of course, if there are nice pictures of the short axis of aortic valve, we can make the diagnosis by the classic fish mouth appearance, as seen here. However, in the real world, with oftentimes less than ideal images, one can get hints of bicuspid aortic valve when we see diastolic sagging like here, or systolic doming of the leaflets in parasternal long axis view. We can also see, as we see on M mode here, eccentric closure line of the aortic valve, just right like there, as opposed to in the middle, it's a little bit more eccentric. So that could be another hint that we may be dealing with bicuspid aortic valve. In the Western Hemisphere, however, by far the most common etiology of aortic stenosis is age-related degenerative or calcific aortic stenosis of a congenitally tricuspid valve. On the left here, we see a severely calcified aortic valve with significantly reduced opening of the leaflets. On the right here, we see a congenitally tricuspid valve, but there is significant calcification, which has led to fusion of the non and the left coronary cusps, leading to leading to this congenitally tricuspid valve appearing more like a bicuspid valve functionally. And before I move on to my next slide, I would like to extend a special thank you to our sonographers in the Echo Lab, Letty, Colleen, and Nasa, for their contribution with these last few clips. So next, we will talk about grading aortic stenosis. We use a combination of aortic valve peak velocity, mean gradient, aortic valve area, as well as index aortic valve area, dimensionless index, all to grade the severity of aortic stenosis. With mild being velocities less than or between 2.6 to 2.9, mean gradient less than 20, aortic valve area greater than 1.5 centimeters squared, indexed area greater than 0.85, and dimensionless index greater than 0.5. Severe being peak velocities greater than 4 or equal to 4, mean gradient equal to or greater than 40, aortic valve area less than 1, indexed area less than 0.6, and DI less than 0.25. Values in the middle would fall in the moderate range. So what echo parameters are paramount for a detailed study and analysis of the aortic valve in an AS study? There are several echo parameters of interest, which can be divided into measured variables as well as calculated or derived ones. So measured parameters include aortic valve peak velocity, mean gradient, aortic valve VTI, aortic valve area by planimetry, LVOT peak velocity, LVOT VTI, LVOT diameter, as well as LV ejection fraction. Calculated parameters include aortic valve area by continuity equation, dimensionless index via VTI, dimensionless index velocity, as well as stroke volume index. In the next few slides, I would like to go over each of these parameters and point out some common pitfalls. So now we'll be going over some parameters which can be directly obtained via 3D or 2D data sets. So aortic valve Vmax, mean gradient, and VTI. For these values, we normally use continuous wave Doppler. Multiple acoustic windows should be used in order to get the highest velocity, with the apical and suprasternal views yielding the highest velocities in most cases. However, use of subcostal and supraclavicular windows for peak velocities especially in those patients with off-axis views, should not be understated. It is critical to measure velocities by aligning the ultrasound beam parallel to direction of blood flow. Only the highest aortic stenosis jet velocity should be reported. We should also report the acoustic window from where the highest velocity was reported, as it usually remains constant on serial studies. Angle correction should not be used because it is likely to introduce more error, especially given the difficulty in predicting direction of jets. The outer edge of the spectral Doppler envelope, as it's traced here, gives us the AVBTI as well as the mean gradient. The mean gradient is actually calculated using inbuilt ultrasound software and is not actually calculated from the mean velocity. Another point to note is that we use an average of 3 or more beats for sinus rhythm and an average of 5 or more beats for irregular rhythms such as atrial fibrillation. It's also important to avoid using post-PVC beats to get mean gradients as well as peak velocities. So planimetry. Planimetry is the direct visualization of valve orifice. It's important to note that planimetry actually serves as an alternative to Doppler estimation of flow velocities. Calcification of the valve can lead to shadow as well as reverberation artifacts, which limit identification of the orifice. So when we do use planimetry, TEE is the preferred modality, as this correlates better with invasive data as well as with the continuity equation. We should also take care to use biplane views, as we see here, to ensure that the minimal orifice area is identified rather than the larger area proximal to the cusp tips. As we can see here, if we move a little bit more proximally, we actually end up getting a much larger area as opposed to the actual area, which is the smallest area. Another additional point of importance is that the effective orifice area and not the anatomic orifice area is the main predictor of outcomes, and that the effective orifice area is significantly smaller than the anatomic aortic valve area, which we measure via planimetry. LVOT velocity, as well as LVOT VTI. We measure these with PW Doppler, or pulse wave Doppler, from the apical approach, either an apical long axis, which is a 3-chamber view, or a apical or a 5-chamber view. Like I said, using pulse Doppler, the sample volume, which is normally about 3 to 5 millimeters in length, is positioned on the LV side, as we see here, just proximal to the region of flow acceleration. An optimal signal has a smooth velocity curve with a narrow velocity range at each time point. VTI is measured by tracing the modal velocity, that is the middle of the dense signal, as we see here, which is then used in calculating the aortic valve area as well as the stroke volume. LVOT diameter is measured in a zoomed parasternal long axis view in mid-systole from inner edge to inner edge of the septal endocardium to the anterior mitral valve leaflet, parallel to the plane of the aortic valve. Some experts recommend measuring the LVOT diameter within 0.3 to 1 centimeter of the valve orifice, while others recommend measuring the LVOT diameter at the level of the annulus itself. It is important to note that in many patients, like we see here, the LVOT is actually rectangular within the 1st centimeter of the aortic annulus. And as demonstrated by the green double headed arrows here, all these different points yield pretty much the same LVOT diameter in this patient, which is the case in a lot of patients. As we see here, they all measure up to 1.8 centimeter. So here we see an example in figure A, for example, where there's calcification protruding into the LVOT, which can yield a smaller LVOT diameter because the calcium may not actually extend circumferentially around the annulus perimeter, as we see here. But if we slightly change the angulation a little bit, we can avoid the calcification and get a much larger and more accurate LVOT diameter. LVEF should be quantified by either biplane method of discs or via 3D dataset. So next we'll go over parameters which are derived based on measured variables, which we just discussed. Stroke volume index. Stroke volume is calculated using LVOT area and LVOT VTI. As we see on this cartoon here, the LVOT diameter is measured from right here, and area is measured using the formula pi r squared, where r is half of the diameter. Using area under the curve of the LVOT VTI, by multiplying those two, we get the stroke volume. Once we index this for body surface area, we get stroke volume index, normal being greater than 35 milliliters per meter squared. As we'll see later, that the stroke volume index becomes especially crucial in cases where there's a discrepancy between aortic valve area and aortic valve peak velocity, as well as mean gradient. So aortic valve area by continuity equation. This is based on the principle that flow going through the LVOT should equal flow going through the aortic valve. So the formula that we just arrived for stroke volume can be subbed in here. And by rearranging the variables, we get aortic valve area, which is equal to cross-sectional area of the LVOT times VTI of the LVOT divided by aortic valve VTI. And last but not the least, we get to the dimensionless index. Dimensionless index is primarily used to reduce errors, which are related to LVOT diameter measurements, which, like we just saw, is squared prior to being used in the continuity equation, which further can magnify any measurement discrepancies if there are any. Dimensionless index is particularly helpful in patients who have a lot of calcium shadowing, which prevent us from getting an accurate LVOT diameter. As we can see, we can get a dimensionless index based on a ratio of the VTIs between the LVOT and the aortic valve, or a ratio of the velocities between the LVOT, or peak velocities between the LVOT as well as the aortic valve. Dimensionless index less than 0.25 corresponds to an aortic valve area, which is 25% of normal and is considered consistent with severe aortic stenosis. So based on the parameters that we just discussed, we can further stage aortic stenosis. Staging is important because this is how we define surveillance intervals, as well as for imaging and for guiding further management of these patients. So based on the 2020 ACC AHA valvular heart disease guidelines, stage A includes patients who are at risk of developing aortic stenosis. These include any patients with a bicuspid aortic valve or other congenital valve anomalies like we talked about, and or aortic valve sclerosis without stenosis. They have Vmax less than 2 meters per second and a normal leaflet motion. Stage B includes patients in the progressive group. These are patients that have mild to moderate aortic stenosis with leaflet calcification or fibrosis of either a bicuspid or trileaflet valve with some reduction in systolic motion, or with rheumatic valve changes with commissural effusion. One important point of distinction between stage A and stage B is that patients in the at-risk group do not necessarily progress further than stage A. However, once in stage B, regardless of the individual rate of progression, patients are bound to invariably go and progress into further stages. So stage C. Stage C is essentially severe aortic stenosis, but without any clinical symptoms. C1 comprises patients with severe AS, but with preserved LV systolic function. The valves have severe leaflet calcification or fibrosis with severely reduced leaflet opening. Important to note is Very severe AS is an aortic peak velocity greater than or equal to 5 meters per second, or a mean gradient equal to or greater than 60 millimeters of mercury. C2 is severe aortic stenosis, but now with LV systolic dysfunction, which is described as an LVEF less than 50%. The valve morphology seems to be the same between stages C1 and C2, but it is important to note that the aortic valve area, although typically equal to or less than 1 centimeters squared, but it's not required to define severe AS. So oftentimes what we do see in practice is that peak velocities and gradients fall in the moderate range, but then the aortic valve area is small enough to fall in the severe range. So how do we explain this discrepancy? Actually, in up to 40% of patients with AS, there are discordant Doppler echo findings, the most common of which are consistent with what we see here. Again, begging the question, how do you explain the discordance? So here we see a step-by-step approach, which was recommended by the European Association of Cardiovascular Imaging, as well as the American Society of Echocardiography in their recommendations on the echo assessment of aortic valve stenosis document, which was published in 2017. We are particularly interested in this low gradient group. So if the aortic valve area is less than 1, and we've excluded all measurement errors and discrepancies, the next step is to go ahead and define our flow status with the stroke volume index that we talked about previously. If we do confirm to have a low flow, that is a stroke volume index equal to or less than 35 cc's per meter squared, then the next step is to go ahead and assess the LVEF. If now the EF is less than 50%, our next step is to get a dobutamine stress echo. So dobutamine stress echo. Here, for example, we can see a patient at rest with an LVEF of around 18%, stroke volume low at 37 milliliters, mean gradient of 14, and an aortic valve area of 0.8. At 20 mics of dobutamine, the EF improves to 27%. The stroke volume increases to 51 cc's now. The mean gradient improves to 37 increases to 37 millimeters of mercury, but the aortic valve area remains small at 0.81. So this is consistent with true low flow, low gradient, or stage D2 aortic stenosis. Note that the improved LVEF and the stroke volume with the dobutamine indicates presence of flow reserve. And this is defined as an improvement of stroke volume by more than 20% during dobutamine stress echo. Presence of contractile or flow reserve has actually been shown to portend a better prognosis than in patients who don't have flow reserve. So what is pseudo-severe AS? Now, if we go on and we do the dobutamine stress echo, and we do get a result with positive flow reserve, then the next scenario is pseudo-severe AS. So at rest here, we see that the LVEF is low at 20%, the stroke volume is low at 36 cc's, mean gradient is 22, and the aortic valve area is in the severe range, that is 0.85. But here we see that with 20 mics of dobutamine, the EF improved, the stroke volume improved, but the aortic valve area also improved to or increased to the moderate range. So like we talked about, the aortic valve area increases with improved stroke volume, and this is consistent with pseudo-severe AS. So what happens if dobutamine doesn't improve the LVEF and the stroke volume doesn't increase? Well, in that case, we have what's called an absence of flow reserve. So what do you do in that scenario? How do you define severe AS in that scenario? Well, then the next step is multi-slice CT and measuring the calcium score. Well, the calcium score values are different between men and women. So for men, calcium score equal to or greater than 2000 indicates that severe AS is likely. A score greater than 3,000 indicates that severe AS is very likely. And in men, less than 1,600 means that severe AS is unlikely. In females, on the other hand, a score greater than 1,200 means that severe AS is likely. Score greater than 1,600 means severe AS is very likely, and a score less than 800 indicates that severe AS is unlikely. So what happens if your stroke volume is low, but your EF is greater than 50%? Well, in that case, sorry about the grainy image, by the way, but in that case, the ASC guidelines suggest an integrated approach in staging of AS. So here is an illustration published by Clavel et al., with Dr. Pibero being the senior author. This was published in JACC Cardiovascular Imaging in 2017 in a state-of-the-art review on assessment of low gradient AS. I find this flow diagram very helpful, especially in this corner right here, when you have normal LVEF, but either your stroke volume is low or your stroke volume is normal. If LVEF is preserved and your stroke volume is low, like we see here, well, this is paradoxical low flow, low gradient, or stage D3 aortic stenosis. What happens if your LVEF is greater than 50% or normal and your stroke volume is normal? Well, the authors of this paper suggest that this is what we call, or what they called, normal flow, low gradient, stage possibly D4 aortic stenosis. This category, interestingly, of normal flow, low gradient AS, or D4, is not well defined in the guidelines as of yet, but it is observed in up to 25% of aortic stenosis patients, therefore being the most common subset of low gradient AS. So just to recap, stages D1, 2, and 3. Stage D1 is our classic high gradient symptomatic severe AS. Patients in this category have severe leaflet calcification or fibrosis of their valve with severely reduced leaflet opening. It's important to note that the aortic valve area is typically less than 1 centimeter squared. However, it may be larger in cases where there is mixed AS and AR. D2, on the other hand, is symptomatic severe AS with low flow, low gradient, and reduced LVEF. Valve morphology looks the same as in D1. And it's important to note that with dobutamine stress echo, aortic valve area is less than 1 with Vmax greater than or equal to 4 meters per second at any flow rate. D3 is symptomatic severe low flow, severe low gradient AS with normal EF, that is paradoxical low flow severe AS. Again, it's important to note that the stroke volume index needs to be less than 35 to be in this category, and it's measured when the patient is normotensive, that is a systolic blood pressure less than 140 millimeters of mercury. Next, I would just like to go over some of these, the different phenotypic features that you can find on echo for patients in class D2, D3, and this possible class D4. So classical low flow, low gradient, or stage D2, patients tend to have EF less than 50%. They do tend to have larger LV cavities, a more depressed LV systolic function, and higher rates of functional MR. These patients tend to be more likely tend to be men and have intrinsic disease of the myocardium. These patients, the depressed LV systolic function tends to be secondary to other intrinsic disease of the myocardium, and most commonly being ischemic cardiomyopathy. Paradoxical low flow, low gradient, or D3. Well, these patients tend to have smaller LV cavities, more concentric LVH, which mirrors restrictive physiology. And that's the reason why, despite having a normal LVEF, they have a low flow state. These patients tend to be older and more likely to be women. And lastly, I'd like to close this category with this normal flow low gradient AS. It's unclear whether it should be classified as moderate AS or severe AS. The 2020 guidelines didn't really address normal flow low gradient AS. However, it tends to be in about 25%, which is the highest subset of AS patients, tend to have this kind of physiology. They do have less concentric LVH, they have less left atrial enlargement, and they tend to have better systolic longitudinal function compared to classes D1, 2, and 3. So what to include in your report? In a comprehensive AS report, it's important first and foremost to start with aortic valve morphology, as well as the etiology of aortic stenosis, to grade the severity of aortic stenosis, and comment on any concomitant aortic insufficiency, as well as comment on the severity if it ends up being significant. It's important to assess the aorta, as well as comment on the aortic root, as well as the size of the visualized portion of the ascending aorta. Presence of LVH, especially if there's concentric remodeling, concentric LVH versus eccentric LVH. Presence of LV systolic as well as diastolic dysfunction. The stroke volume, especially if there's a discordance between aortic valve area as well as mean gradient and peak velocities. Size of the LV cavity, as well as presence of left atrial dilation and the severity of the enlargement. Presence of pulmonary hypertension as well as pulmonary pressures. Presence of any other significant valvular abnormalities. And then finally, recommendations for any further testing. So just to recap, today we talked about various etiologies of aortic stenosis, grading of AS. We went over measured as well as derived echo parameters and used those to help stage aortic stenosis further. And then finally ended with talking about what to include in your comprehensive aortic stenosis report. And with that, I would like to give it to the moderators and to the speaker. Thank you everyone for listening and for joining me in my quest at lifelong learning. Thanks everyone.
Thank you so much for that very excellent and very detailed presentation. I really so much to learn. I wanted to ask Dr. Waller the first question, if you wouldn't mind, how do you approach when you are reading a report and you see that the valve area is in the severe range, but yet all the other parameters such as the gradient does not seem to match up, and overall when you're looking at the valve it appears restricted and heavily calcified? Like, how do you approach reading an echo like that?
I think that's an excellent question, and I think Aishwarya did a very nice job, making sure to include things like what the stroke volume is, to make sure that to see whether or not you're dealing with potentially a low flow, low gradient AS, and also the question then becomes: are your measurements correct? And should you reevaluate what measurements you're using? And should you try to use tools like the dimensionless index, which could have value to remove errors that could occur from squaring the radius? So.
Yeah, no, absolutely. It's very important to make sure that your stroke volume measurement is correct, as well as your radius. Dr. Harb, how do you approach echoes like that, where the valve area is, in the severe range, and yet the gradients may not meet the severe range?
Actually, it's a great question, and despite the presentation was excellent, and highlighting the use of the vitamin echo. However, I tend to rely honestly more on cardiac CT. So what I actually do in these cases, because most of the time it's challenging to go back, as Dr. Waller mentioned, and most of the time it's maybe an inaccurate measurement. The sonographer didn't do all the interrogations to find the peak highest velocity. So I find it very easy. And nowadays, many patients have already like CAT scans for various reasons, or a CT chest without contrast. And what I typically do is I look at the CT and measure the aortic valve calcium score, which Dr. Bhardwaj mentioned, you know, how useful it is. I think it's useful in multiple parameters, not only to assess the severity of aortic valve stenosis, but also, you know, in planning TAVR, you can see how much calcification there is, where the calcification is, how the annulus is shaped. You can assess the sign-tubular junction, the ascending aorta. So you're already, like, you know, also having an idea about planning the procedure. Is this a good TAVR candidate? Do I see a 5 centimeter ascending aorta that will push me more towards surgery? We do use in our lab the vitamin echo, not to say it's not a great tool, but I feel like, you know, with how easy CT is, how safe it is. Remember, these people with severe aortic stenosis, most, you know, have very commonly concomitant coronary artery disease. So, and sometimes you don't have the cardiac cath. So subjecting them to dobutamine, while it's published and safe and the literature supports it, may not be, in my opinion, as safe as just looking at the CAT scan, looking how much calcified the valve is. What do you think, Dr. Waller?
No, I completely agree. I mean, I think if you have a CT, or if the CT was being performed in terms of TAVR planning, you have the information there. And, you know, it's very straightforward to do, you know, the calcium score of the aortic valve. Very easy to do, very reproducible. And maybe not all labs are doing dobutamine stress echoes because of the time it takes to perform and the risk.
Dr. Waller, along these lines, if I may ask you, do you find a value in cardiac MRI? Just we were speaking multimodality now, in terms of specifically to assess the severity of aortic stenosis. I'm not you know, talking about measuring the annulus in people who are not, you know, candidate for contrast with IVs with CT, and not for the LV and looking for amyloidosis, just specifically to assess the aortic valve severity. Do you find value for cardiac MRI there?
So I mean, I think it's an excellent question. I think you know, aortic stenosis has been one of the areas that has always been evolving in terms of how we image and how we evaluate. So initially, everything was echo, and then when we found that CT was superior, you know, CT is now utilized for pre-procedural planning. One of the advantages of CT over MRI is obviously the ability to evaluate calcium, which we don't see really with MRI. MRI could be useful in terms of looking at the velocities, the peak velocity, the gradient, and you may be able to do aortic valve planimetry, but I would say CT is superior for that because of the reasons partially that you mentioned and that we're talking about now. MRI is great for overall LV function, LV size. You know, are we seeing that the heart has been impacted by the aortic stenosis? You know, and if you're talking more, if you're trying to differentiate between C1 and C2, you know, maybe there's a value there for MRI. But I think in terms of severity, we would tend to look more at CT, with echo always being our first line.
Thank you.
Yes. Thank you, and definitely the valve score has been proven to be very helpful in patients with normal EF, and yet, you know, lower stroke volumes in order to determine degree of aortic stenosis. There's been a couple of questions coming into the question and answer section box at the bottom of your screen, so feel free to enter in these questions. And, you know, there's been a couple of questions that have come through specifically on a dobutamine stress echo. Since we're on that topic, you know, when you're doing a dobutamine stress echo, you know, what is the maximum dose that you titrate the dobutamine to? And what does it mean when your mean gradient is less than 40 at 20, but yet higher at higher doses of dobutamine? So I don't know if Dr. Waller, Dr. Harb, one of you want to answer that question.
I mean, we typically stop, you know, if it's specifically a challenge for AS, we usually stop at 20 mics per kilogram per minute. And the question then becomes, you know, was there an increase in stroke volume and an increase in gradient? So we usually don't go to 40. I don't know, Serge, if you want to comment.
Yeah, same here at the clinic here. We typically stop at 20. For specifically when it's the aortic stenosis is the question. Now, if the coronary artery disease is the question, sometimes we go higher up to 40, but for AS, we typically stop at 20.
Yeah.
Another excellent question. I think this has been a topic in a recently published JACE article as well, but traditionally we were told, do not measure the post-PVC gradient. What are your practices now? Do you still avoid measuring the post-PVC gradient, or do you use that as a surrogate of what it may show on a dobutamine?
So, I mean, one of the things our lab always does is we make sure that we get a good number of gradients that we could actually look at, just in case there are PVCs, and to ensure that it's not a post-PVC beat that we're evaluating. Especially if there's a lot of ectopy, we try to have more beats. As Aishwarya mentioned, you should be averaging 5 beats instead of 3. So we typically are not using the post-PVC beat. I don't know, Serge.
No, similar here. I think it's a great question. We tend to avoid these. What was Lucy? You mentioned about a recent paper that looked at this. Can you please brief us about it?
Yeah, so recently published that, we were traditionally told not to use the post-PVC beat, but if you think about it, post-PVC increases your stroke volume. And so if you have that increase in stroke volume and you see that the peak velocity is greater than 4, you can hypothesize that when you do the dobutamine, that perhaps you do truly have severe aortic stenosis. So it's a great published paper recently published on that. So just again, moving down the questions, just because we have a couple of them. When do you perform a TEE to better differentiate and evaluate aortic stenosis in your practice?
So, I mean, a great use of it would be if you feel like your LVOT diameter is not accurate. If you feel that aortic valve planimetry would be added value to your to better define the valve. So those are usually the two reasons.
No, completely agree, because I think, as you mentioned, Dr. Waller, measuring gradients by transthoracic echo is probably superior than transesophageal echo because of the sedation and the patient setting. And, the challenging being coaxial, having to go transgastric, flexing, and, which is uncomfortable for the patient. And, with the effects of sedation, as you mentioned, measuring all these parameters that you mentioned, or when you can see by transthoracic echo, the quality is suboptimal and you just need to look at the valve. So probably a TEE would be the next tool to look at the valve.
Mm-hmm. And I just want to add to that, it's helpful to do a TEE when you're not exactly sure why the patient has aortic stenosis. If you don't quite understand the etiology, whether it's a congenital abnormality, bicuspid, unicuspid, or if they possibly have subaortic stenosis or supravalvular stenosis, a TEE is very helpful in that. And you can really further assess the morphology of the leaflets. So there was a question here as well.
Just to add to that, I would say we're mainly talking about native valve. When you're talking about prosthetic valve, I think being able to evaluate the valve, with TE is actually, obviously more superior. So if you're talking about valve and valve, evaluate, potentially valve and valve procedures, there's added value to TE.
Mm-hmm. And I definitely like to do the multiplanar reconstruction of the LVOT, again, to find the best LVOT diameter to use in your continuity equation. So there's a lot of benefits to using a TEE if you need it, if the transthoracic is not sufficient. There's a couple of really excellent questions coming in about, comment on screening for amyloid with aortic stenosis and whether or not you use global longitudinal strain as part of your report. If either of you want to tackle that question.
Sure. I think if you don't mind, Dr. Waller, in our lab, global longitudinal strain is becoming integral part of the report. We typically do it systematically, and I think we've been doing it for many, probably around 3 to 5 years. I don't know the exact dates when we started reporting it. I think it does have a diagnostic, but also a prognostic value. The prognostic value has been emphasized in multiple papers showing that altered global longitudinal strain will impact your survival and may be helpful in the decision to make, particularly in the group of patients that Dr. Bhardwaj mentioned, which are the asymptomatic severe aortic stenosis, when to operate. Maybe global longitudinal strain can help. I think it also is a useful diagnostic tool because of the prevalence of amyloidosis in this group of patients. And if you see apical sparing, you start questioning, does this patient have underlying AS, particularly given the studies that showed a relatively high prevalence of amyloidosis in patients with severe aortic stenosis. What do you think, Dr. Waller?
No, I completely agree. Our lab has also been doing routine global longitudinal strain really on all patients. Just one, it makes our sonographers better at measuring it, but also to pick up, amyloidosis. So in this group, I think it would be worthwhile to include it in the report.
Yeah, absolutely. Great questions. I have a question that, when you have very technically challenging pictures, and you have a very high suspicion of having severe aortic stenosis, but yet your gradients are not there, how often do you use echo contrast in order to help delineate and amplify the velocities across the valve?
So we tend to more routinely do it for TR in terms of it's just been adopted that way. I think if we're not getting good gradients or we're not seeing the valve very well, it's probably going to be additional testing that's going to be performed. At least that's the practice in our lab.
Dr. Harb?
Same here. I completely agree. I mean, we use it more to amplify the TR signal. I don't know how much, this amplification is, I don't know how to say it, like reliable in terms of, can you use this data? Because probably most of the published data was without this, but we don't typically use it for aortic stenosis to amplify the aortic valve gradients. We use it mainly in aortic stenosis if you cannot see the LV segments well, but this is something different.
And it's saline often that we're using for the TR, right?
Exactly.
So
not the LV contrast.
Not commercially available contrast agents.
100%.
Very, very great. So I do sometimes use echo contrast, to help delineate the velocities. I find that it is helpful. You just have to make sure that you adjust your settings for it. So, another question, and I knew this question was going to come through because it seems like it comes through in every aortic stenosis presentation, but, what do you do when there's high subaortic velocities?
So that's a great question. So one, I guess the question is, are we dealing with a subvalvular gradient or are we talking about a high flow state? And, have you excluded aortic insufficiency, or what's the underlying cause for the high flow state? So I think it's a great point, and it may drive additional testing.
Great, thank you so much. And another role or question of the role of dobutamine stress echo and functional mitral regurgitation and aortic stenosis. How do you feel that affects your stroke volume, and do you think that it adds challenge to the dobutamine stress test? Dr. Harb, have you noticed that when you're doing DFTs?
That's a great theoretical question. I think it's a great concept that if you have mitral regurgitation, you'll have less stroke volume, so it may impact the dobutamine stress echo. I think it's theoretically a very plausible point and well thought. Typically, again, in these cases, if you're in doubt, I think there are, as we discussed earlier, other, elegant techniques that can give you the answer which are safe and very easy. And most of the time, the patient have aortic, have a cardiac CT. But along these lines, I mean, the topic of functional mitral regurgitation in the setting of severe AS is a very interesting topic. Theoretically, you would think that, functional MR would improve when you treat the AS, but practically and clinically, it doesn't seem to be the case. What do you think, Dr. Waller and Dr. Safi, both? I'm interested in both your opinions.
No, I mean, I agree immediately. I mean, I guess the question is, over time, is it going to get better?
Dr. Safi, has your experience been that they do improve? Have you seen improvement, or most of the time they remain or get worse?
You know, we're always optimistic that it's going to get better. You know, you walk in as a total optimist, and then, you know,
Of course.
we find that it really doesn't change too much. Like, you do TAVRs on these patients, and the MR is the MR, but you know, that's just, you know, in my experience, it doesn't seem like it really gets better after you do a TAVR on these patients.
Similar for the functional TR, I think. You know, theoretically, you would think, okay, you know what, the pulmonary pressures will go down, the RV will remodel, and the TR will decrease. It doesn't seem to be the case. And I think the published literature supports this in both surgical aortic valve replacement and TAVR, in terms of, you know, not having a dramatic improvement of these function MR and TR.
Mm-hmm. You know, in sinus rhythm, do you record the maximum peak velocity, or do you still average 3 beats when you're reporting?
So I think it really depends on the quality of the images that were recorded. If they're all good quality, you know, you're probably going to average the 3. If you feel that one is the best envelope and the rest were not good envelopes, maybe you might end up taking the highest. You know, ideally you'd have all of them are going to look very similar.
Mm-hmm. Yeah, usually they recommend 5, averaging 5 for atrial fibrillation, or 3 for sinus. But again, you could look at the R to R intervals, and if they're pretty similar, even in AFib, you know, I usually, you know, average 3 to 5 depending on how things look.
But I think one of the important points to point out is to make sure that you're doing additional views, you know, with the Pdoc, to make sure that you are getting the highest gradient.
Mm-hmm. And how often does it happen at your lab that a Pdoc probe is used, and do you find it helpful?
So the Pdoc probe is always used in our AS cases. Yeah,
Mm-hmm.
and you know, it's helpful especially for serial repeat studies, you know, in terms of where did we get the peak velocity, the highest peak velocity.
Similar here. I think in every AS study we use PW. It's just part of the exam. Just because of its value, as Dr. Waller mentioned, sometimes you can get the highest peak gradient through the PW, you know, in a non-typical view.
Yeah, absolutely. I think it is part of a complete aortic stenosis study. And, you know, but that being said, if you have multiple serial echoes and, you know, the Pdoc probe never really gives you good gradients and you get great gradients in the 3 and the 5, you know, it does make sense if you're doing a limited echo to just focus on the views that work for you. And I think that's important to look at prior echoes, not just the reports, but the images. And, you know, going into a study, if you are a sonographer, to kind of know that beforehand, I feel like is very helpful.
Lucy, what do you use in severe asymptomatic aortic stenosis? Patient is truly asymptomatic. How do you go about? You know, we all know the criteria by guidelines, but practically, can you tell us how you go about? Which markers do you use to push more towards surgery or observation?
Yeah, I mean, great question. You know, these are the tests that stop your heart, right? When you get a severe AS patient, you make them walk on a treadmill. But you know, there's a couple that come through a year when it stops your heart, and you look for any kind of reason to stop the machine. But yeah, I mean, you usually, you know, if you have a very high clinical suspicion, if the murmur is severe and you're just, you use your clinical judgment, you know, by guidelines, I think you put them on a treadmill and you start off really slow, whether it's modified Bruce or Bruce protocol, and you go in to see how many METs they can do. And if they can't do age appropriate amount of METs, then, you know, they're probably not as asymptomatic as they say they are.
Do you use BNP or any biological markers?
No, currently I don't in my practice. I know that, you know, I'm really excited to see which way those markers go. But right now, you know, I would use a treadmill, just if not for nothing, just to kind of document his or her functional capacity, you know, and just follow them closely.
For these patients, Dr. Waller, if the patient is asymptomatic with severe AS, and you're still, you know, on the borders of intervening or not, do you ever offer TAVR, or it's only SAVR that you offer?
I mean, it's a good question. I think with the, you know, aortic stenosis, like I mentioned before, has been evolving, and it's always going to be a discussion now, I think, with the patients. A lot of patients are favoring TAVR over SAVR or requesting TAVR over SAVR. I think is the point. Even younger patients thinking that maybe they'll do a valve-in-valve 10 years later or 15 years later if needed. So I think it ends up being a discussion. And, it's a good point that you bring up about checking BNP. Are we differentiating, C1 versus C2? Do they have changes that are occurring even though they appear or report that they're asymptomatic? Are there findings that have changed? And maybe that's where a role where MRI might be useful in terms of looking at fibrosis or looking at actual structural changes that may have occurred.
Along these lines, sorry, go ahead.
No, I was just going to add, that's possibly why, strain imaging may have a role in the future in these kinds of patients to pick up the, the very subtle changes in LV function. Sorry, go ahead, Dr. Harb.
No, exactly. Sorry to interrupt you. So along these lines, do you guys, Dr. Safi and Dr. Waller, see any, between ages 50 and 70, the guidelines say you have to talk to the patient about the valves, but is there, do you still, talk about mechanic? It seems that the mechanical valve in this age group has been fading out because, as Dr. Waller mentioned, people are talking now at, what, I'm 55, let me do a TAVR, in 15 years, I'll do a valve-in-valve. Do you get this in your practice, or do you see a decline in mechanical valves for this age group, and do you see it as an option fading out?
I think people have a preference for TAVR. I think for multiple reasons. I mean, unless they're going for concomitant surgery for another reason, we are probably going to see a more utilization of TAVR over time. Historically speaking, again, aortic stenosis has been evolving. Like it used to be, if it was a young patient, it would be, especially male, it would be a mechanical valve. And now the dynamic has shifted where it was initially just high-risk patients would get, or prohibitive patients would just get TAVR, and now high risk, and then now intermediate risk. So I think it's evolving what we're going to be seeing in the future.
Yeah, no, and it's going to be really hard to kind of recommend mechanical valves, and I think that the age cutoff is going to keep decreasing in time, and it's it's pretty interesting to have a thought exercise. Do you recommend TAVR, then then SAVR, and then a valve-in-valve TAVR, or do you do SAVR, then TAVR, and then a valve-in-valve TAVR? I mean, what order do we do it? I mean, if you think about it, the younger patients are probably going to be some sort of anatomical variant, right? So should we do like a minimally invasive AVR and then plan to do a TAVR down the road? Which order? I think that hasn't been proven, but you can argue multiple different kind of formats.
No, this is a great point. And actually, the way I think about it right now between TAVR and SAVR, we used to think about it, high, prohibitive risk, high risk, intermediate risk, low risk. It seems to be shifting now as, do you have a favorable anatomy for TAVR, regardless of your risk? Because, TAVR has been validated everywhere. So do you have a good anatomy, as Dr. Safi has mentioned, for TAVR? Meaning, look at your CT, do you have a good size annulus? The aorta is not dilated, you don't have severe concomitant multivessel coronary artery disease. So the question becomes, instead of, are you high risk or low risk, do you have a favorable anatomy or not? If you have favorable anatomy, go for TAVR. If you don't have favorable anatomy, go for SAVR. I mean, I'm not, advocating one way or the other. I'm just saying that some people are advocating this thought process, and goes along with what both Dr. Safi and Dr. Waller, you've been saying,
Yeah.
Well, I think that's where the shared decision making.
Yeah, absolutely. So much to talk about.
Yeah, exactly.
And I look forward to the future E3 lecture on TAVR, which will be this summer. The next ASE E3 lecture is on June 1st due to the Memorial Holiday. So that's a Tuesday, June 1st. It's going to be on tricuspid regurgitation, and I really hope that you all can join in. I want to thank you, Dr. Waller, Dr. Harb, and Dr. Bhardwaj for a great presentation and for being part of our panel today. I really appreciate it. Thank you so much.
Thank you very much.
Have a good night.
Thank you.
Good night.